Good morning, good afternoon, ladies and gentlemen. Sorry about the good morning. It's been a long day, but been a very enjoyable day. So, a very warm welcome for coming to our annual review. First of all, introduce our top table on the far right of me, not politically, as our Chief Exec, Jane Grant. Jane's been with us for a year now, making a huge contribution to our organisation. And immediately in front of me we have Angela Wallace, our Director of Nursing, Tracy Gillis, our Medical Director, Fiona Ramsey, our Director of Finance, Helen Kelly, our HR Director, and Graham Foster, our Director of Planning and Public Health. We also have other senior staff in the front two rows, so any difficult questions, if it's more appropriate to refer them to them, we'll be calling on their actual services. Okay, this is a non-ministerial review. Last year we had the Cabinet Secretary. This year I'm afraid you get to do with actually me. We have Jim May, Senior Government Official, so very warm welcome. There's Jim there. Very warm welcome to Jim. You got a package you come in, it's got a lot of good information, the annual report for last year and one of our community news. I would hope that you'll take time to read it when you go home tonight and keep pace with what we're actually doing. I'm going to do a brief introduction, talk about our challenges and our achievements. We'll then have a series of speakers. At the end of each section, we'll take some questions, then we'll have a final question and answer session at the end. So any burning questions, we'll take them as we go through. So this is your chance to hold us to account. I'm very, very conscious that it's your taxes that we actually spend. So it is important that you understand what we're spending it on and what we prioritise. So please hold us to account. So these are our main priorities: making sure people get the appropriate treatment. It's delivered in a safe and caring environment. Health is very seldom out the news, and on Monday there was a major report issued on the Vale of Leven. Hopefully by the end of today we can reassure you that it couldn't happen here, but we can never be complacent. Very much listen to patient experiences, and that's at the heart of what we're doing. That's going to the journey that we're on just now, very much learning from people's experiences, making sure the care that we delivered is person-centred. It takes account of people's individual circumstances as much as we can. Very much working in partnership with other bodies, local authorities, other statutory bodies, voluntary sector, our staff representatives, and we've now started formal integration of health and care with local authorities, and that's something that we're embracing energetically, and very much working with our staff. I never forget that we are a people industry, and our services are only as good as our staff allow them to be. And it is important that staff are confident, well trained and actually motivated, and that's our objective. The landscape that health has been delivering continually changes. Politicians keep telling us they maintain budgets in real terms, and that's very, very good relative to a lot of other public services where there's a lot of real-term cuts. But while they're doing their best to maintain budgets in real terms, it's not enough to keep pace with the continual demands on our shelves. Technological advances are opening up new sort of treatments. People's needs and expectations are increasing, populations rising. And as people get older, a lot require services to help maintain a quality of life. And a lot of these developments and treatments and medicines have two things in common. They're very good for the patient and they're very expensive for us. So we always have to run to actually stand still. We have to make efficiency savings each year about 3% a year. So we have to keep looking at what we're doing if we're going to keep a relevant health service to yourselves. And these are some of the numbers looking at the future population's going to go up by 10% over the next 25 years. The number of people over 65 is going to be 50%, over 75s, 100%. And that's important for us because invariably we get into very expensive healthcare. It's good that people live longer, but it is expensive to maintain a lot of these people. And these are all the numbers. Every part of health is seeing quite a big expansion in the number of people that we are required to treat. So our approach is very much focusing on health improvement in the early years. Prevention and self-help are words that you're going to hear more as we have to treat more people. Then getting people to take more ownership for their care is going to be more and more important. That's something we're going to drive. Making sure people stay at the centre of everything we do, and that's going to be very important as we go into health and care integration, where we merge the health culture and the local authority culture, bring in the voluntary third sector and create seamless services. It's going to be a huge challenge, but it's one that we have to get right. And if we keep people at the centre of everything we do, we won't go far wrong. To make sure that all our services remain fit for purpose, we are carrying out clinical review just now. You'll hear more about that from my colleagues. But it's terribly important that we are confident we're making best use of the resources in the health service. They are sustainable. We're looking at future demands and we're gearing up to meet that future demands. And I say very much working with our community planning partnerships. So that's the things that's going to drive us as a health board. In terms of health improvements, I think Scotland's got quite a proud record of what's been achieved over the last 10, 20 years. In Forth Valley, I think we've exceeded on the national position. The amount of premature deaths from strokes has come down tremendously, and again the target we've got from the government, we're exceeding that, and that's really, really good news. Likewise with the heart disease, again we're improving on the actual target. Alcohol brief interventions, again we're going that extra mile and exceeding the government's targets by nearly 50%. And child healthy weights, again we're doing a lot of work, and that's all about encouraging people to adopt healthy lifestyles. Individuals can make a huge difference to their future health conditions. And these are just some of the numbers. They're all in the actual pack that you've actually got. But we are a big organisation, but for every person who uses our service, it is a personal experience. So it is important that we gear ourselves up to deal with the volume, but within that we give people a personal experience. The first slide shows the amount of traffic we have through the actual hospital, 613 admissions outpatients, 77,000 to emergency department, 60,000 inpatient day cases, and 3,220 babies born a year. So quite big numbers. And the next slide shows the number of activities we have in the actual community. GPs, bulk of that, 1.5 million a year, a lot of activity. Community nursing, 450,000, dental, 650,000, and pharmacy activities, 1.3 million. So we are very much a volume business. Sometimes we get it wrong, but we strive to get it right all the time. I want to say a wee bit about patient-centred care. That was very much at the heart of the Daily Leaving report that was issued this week and other major reports. We've spent a lot of time studying these reports. Well, the Daily Leaving only came in a couple of days ago. It's 400 odd pages, so we're still working our way through that. But we very much study these national reports that are produced to see what we can learn from them. And at the board, we take patient safety very, very seriously. We never forget why we're actually here. And at the start of each board meeting, we start off with a patient story, and that keeps us focused on what is important. What we're driving out is part of the government's national patient safety programme. And there was an annual conference on that a couple of weeks ago. There's over 800 delegates, mainly people within the health service in Scotland, although the people from health services all over the sort of world also acted, but mainly it was from Scotland, over 800 people. And individual boards were asked to give examples of what they were doing on patient safety in the form of a poster. And I'm delighted to say that we were actually voted the best patient experience. And that was voted on by the people at the conference. So that was the people on the know who had voted that our patient journey was the actual best. So much so the Cabinet Secretary came out to visit, well, now the ex-Cabinet Secretary, but at the time it was Cabinet Secretary, came out last week to visit to see what we were actually doing, and he was actually hugely impressed. So well done to all the staff, the way they're driving that. Yeah, definitely. And I'm going to come back on the staff in a minute, so don't save your applause for later. Again, mortality, that's people who die in hospital, invariably that is carefully measured. And again, one of my colleagues will come on to that, but there's a mid-Staffordshire review where there's a lot of unexplained deaths, and we've spent a lot of time studying that and learning from these unfortunate experiences. Well, for two major external inspections, one by the Healthcare Environmental Inspection team who visited the community hospital in Falkirk, and surprisingly they never made one single recommendation. Now that's practically unknown for an inspection body not to make a recommendation. They were very happy with what they've seen and they described it as exemplary. So that was tremendous, again, to the staff for achieving that level of service. And we had the older people in acute hospital inspection. Again, it was a very positive visit. We made one or two recommendations, but in the whole, it was a very, very positive report, and they congratulate us for our transparent approach. So when you get these external inspections and you come through with flying colours, it's great credit to the staff for what they're actually doing. Briefly mention the Vale of Leven report because it's been in the news this week, and it's very, very unfortunate what happened there. It refers to incidents about 6-7 years ago. Thankfully, health service generally in Scotland has moved on. We are looking at that very, very carefully, as I said, to see if we can learn anything from that. I think I can say quite confidently what happened there couldn't happen in Forth Valley. I hope you'll agree with that. But notwithstanding that, we are not complacent, and we will study that report very, very carefully, reflect on what it's saying, and any learning we will build into our procedures. Now, so far it's all been good news, but we are not perfect as an organisation. I think we are good, but we're not perfect. One of the areas where we haven't been so good is on waiting times. And a year ago, our performance on the national standards was one of the poorest in Scotland. However, I'm delighted to say there's been a huge amount of effort done in the last year, and we're getting very close to the pack. Again, Chief Exec will talk about that in actually more detail, but that is a high priority of the board to make sure that our waiting times are as good as anywhere else in the actual country. Emergency care is always a major challenge. You just don't know who is actually going to turn up at emergency care. It's an expensive service to run because you've got a lot of different disciplines there to deal with people. There is a target dealing with 95% of people within 4 hours. We're achieving about 93%. Some months we achieved 95%, but it is a struggle for us. Likewise, delayed discharge, we struggle when people have had their treatment in hospital, moving them back home or back into residential care. That's something we jointly do with councils. Again, it's a major priority with us and councils. particularly Falkirk Council, to try and get a sustainable solution. Not quite cracked it yet. We're hoping the clinical service reviews will help us make sure all our services are sustainable. We very much want to involve the public in that process. We'll be going out to consult on our services as part of that, and that information will feed into our next healthcare strategy running from 2015 to 2020. And again, we will go out and consult on that actual document. National awards. Delighted to say we've been successful in a number of national awards. I won't go through them all just now, but it's gratifying that we're up there amongst the best in Scotland. And the final slide, you'll be pleased to see final slides from myself. Just immediately before this session, we had a staff award, and recognising the good practice within our health service. I could say it was a very, very uplifting experience. First year we've actually run it. It was run as Celebrating Success a number of years ago, and we actually had 356 entries for that. Tremendous to get that level. And reading them, some of the entries, the way staff are going that extra mile for patient care is tremendous. As I said, we're not a perfect organisation, but there are an awful lot of staff are going that extra mile. Absolutely tremendous. So I think we should give them all a round of applause. So finally, I just want to say we want to work with the public and our staff to make sure that our health service is the best in Scotland. And with your help, we can achieve that. Now I'm delighted to pass over to my colleague, Graham Foster, Director of Planning and Public Health. Thank you.
Thank you very much. That's me on this end. This morning we had the staff awards. We were all on very strict instructions to stick to time, and we were warned if we went over time we'd have a hook and we'd be pulled off stage left very abruptly. If I do suddenly disappear off stage left this afternoon, it's because I found the corner of the stage with my chair leg, not because I'm being hooked off for speaking too much. So I'll try and sit very still, but as my colleagues will tell you, I'm not very good at sitting still, so if I fall off the stage, my apologies now. I want to tell you first of all about the clinical services review. This is quite an important piece of work for NHS Forth Valley, and it's going to take a lot of time from a lot of our staff, and hopefully a lot of time and engagement from patients and the public over the next few months as we start to set our direction going forward, working into developing a new healthcare strategy. In your pack, you will find you've been given a copy of our community health news. It looks like that. And it is published all about the clinical services review, so it's to give you all the information about what's happening and the way we've set it up. Just to give you some background, I think it helps to understand why it is that at this point in time we're having a significant pause and a think about how we provide healthcare services going forward. The National Health Service was founded in 1948. That's a very long time ago now. The world in 1948 was a very different place. We'd only just finished a world war. Most houses in Britain had outside toilets. Central heating didn't exist. Damp and overcrowding were quite the norm in many homes. And it's understandable that the National Health Service, created in 1948, focused on building hospitals where people could be brought to recover, where they could lie in clean sheets and be kept under a dry roof and in warm conditions and be cared for. And that was entirely appropriate. Technology was extremely different in 1948. We did not have the ability to provide rapid operations that people could recover from very quickly. We didn't do endoscopic surgery. We didn't even do things like hip replacements and knee replacements, which are the bread and butter of our service every day today. So the National Health Service was a very different place. And for the first time, people got access to general practitioners, so they could actually go and get healthcare advice. but those general practitioners worked primarily as gateways into the hospital-based service. The model of the National Health Service going forward from then has largely focused on hospitals and caring for people in hospitals and that gateway idea of primary care. The world that we live in going forward in the 21st century is now very different. We have new technologies, we have new ways to treat people. We almost invariably, but not always, have much better housing. We have better community support services. Most people would actually rather be in their home than be in a hospital ward. Certainly our elderly patients would rather be cared for at home than be in nursing home care if that can be avoided, and certainly don't want to be stuck in acute hospital wards. The government has published the 2020 Vision, which is an inspirational document looking forward, which charges us to look at how we can begin to provide care services, health and social care, that supports people to live longer, healthier lives, either in their own homes or as close to home as possible. And that means we need to begin to focus on taking care out into the community to help people in their homes and to support people in their homes, rather than automatically assuming that we can sit in this lovely building and have patients brought to us. Later on in the presentation, in the afternoon, we're going to show you a video. It's called John's Story, and it's actually a health and social care integration story, but I think it very clearly sets out the picture of how you can care for people in their own homes in a much better way than we have been doing, and that's quite an inspirational video, so we'll wait to show you that later in the presentation. The 2020 Vision is supported by a workforce vision, which is about us all developing our skills to service that. In order to do the clinical services review, we've set up a number of structures, but we absolutely want it to be about engagement with public and staff and with patients. So one of the main things we've done is we've set up a website and we've set up these various ways in which you can input to that process. So you can log on to nhsforthvalley.com, you can follow the pathway to shaping our future, and there are a set of questions there which you can fill in about any service that NHS Forth Valley provides, and we will pick that up in the planning department and add that into the processes that are going on with the clinical services review. And we very, very much do want people to get involved. We also, in each of the various groups that we've set up, can I have the next slide, in each of the various groups set up a patient engagement process, and that's about making sure that people get involved. The clinical services review will run for at least 6 months. It may take us a bit longer, but the plan at the moment is to try and keep it to about 6 months. And we're in the first phase. So in the first phase, there are 3 main questions that we're asking, and these are those questions. So what we're looking for is information about what is important to the public when they use our services. What could we do to improve those services for patients and their families? And is there anything that you would wish us to change? So that's our starting point for the review. And really up until about Christmas, that's the sort of information that we'll be gathering. So next slide. Across the whole of the service, we have values and things that we're trying to address. And this slide just sets out some of the core things that we want to deliver across all of the clinical services that we provide. So we want our care to be safe, and that links to what the Chairman was saying about the Vail Inquiry and so on. We want our services to be effective and efficient. We want our services to be absolutely patient-centred, about providing patients with a service which is built around them, not built around us or the doctors or the nurses or our traditions or anything like that, built around what patients need and flexible. We need to have a strong focus on health improvement, because if we're going to help people to live longer, that's how we achieve that. Far better to prevent diseases than to try and catch up later. Alongside the 2020 Vision is the Christie Commission report, which very clearly sets out that challenge for public services in Scotland. If we're going to balance our books, we have to be better at preventing diseases and staying healthy, rather than constantly running to catch up by treating them. It's incredibly important that we achieve financial balance. You only need to watch the news items about public services that get out of financial balance to recognise the challenges that brings. If we want to deliver a proper service for Forth Valley residents, we absolutely need to stay in financial balance, and that's a big challenge for us. So we need to be thoughtful and imaginative about how we can actually do that. So we're trying to be better every year, but costs are going up, particularly healthcare costs, and that is quite challenging. So financial balance remains important. And we absolutely need to look after our workforce, because they're the engine room of the service that the National Health Service provides. Almost everything that the National Health Service is based upon people doing things with people, and therefore we need that very effective workforce, and we need to look after that workforce, and we need to develop them. And we also need to have the right values. So again, the chairman mentioned the Francis report and the Vale of Leven inquiry, and a lot of the things that have gone wrong in places have gone wrong because people have lost sight of the core values. People haven't communicated, people haven't put the patient at the centre, and these things are really important. So it's important to us as a team that we deliver on those values. So next slide. So the clinical services review has been established in 8 work streams. Again, they're detailed in the document that we've given you. Each one is led by a senior clinician and then supported by a team of other colleagues who will be able to help them. So we've got some management support, we've got public engagement support, we've got planning support. And each of those work streams will be looking to meet with public, meeting with voluntary groups and so on, and reviewing all the areas of that clinical group's expertise. We will then bring all that information together into a final document, and that final document will help us to decide what our challenges are going forward and what our healthcare strategy will be next year. Next slide. So this is really the pattern, and this slide was really just to remind me and to remind you that the clinical services review doesn't stand alone, because NHS Forth Valley does not stand alone in this. We also work jointly with our social services partners, with local authorities and so on. And so we have the Health and Social Care Integration Bill and the Health and Social Care Integration Programme running. And that runs alongside the Clinical Services Review. What the Clinical Services Review will help us to do is to understand what the NHS absolutely has to deliver, and will allow us to engage with that Health and Social Care Integration agenda. And on the other side, I've put the Community Empowerment Bill, which has had probably less of a profile. But this is also a bill that recently went through the Scottish Parliament, which is all about making sure that the strength of communities is increased and the voice of communities is increased, and it puts a statutory duty on public bodies to consult with their communities and to work with their communities when developing services. So that's really important as well, and that's the Community Empowerment Bill. It also very much puts community planning processes, which are our local authority planning processes, at the centre of what we do. So the 3 things together, that's our clinical services review and the healthcare strategy, health and social care integration, and the community empowerment are the things that will come together to help us deliver that 2020 vision of more people, more healthy, closer to home. So can we move on? So that's about the clinical services review. If you have any questions about it, feel free to use that web address and feel free to ask questions afterwards. But we just want to hear from people at this stage the answer to those 3 questions. Now, moving forward, just a short bit about improving health and reducing inequalities. As well as being Director of Strategic Planning, I'm Director of Public Health, so that's why it continues with me. I'm going to tell you about this and then we'll pause for some questions. Under the process of the Community Empowerment Bill, I mentioned community planning partnerships. And community planning partnerships are the local bodies which are a partnership between local public services, NHS and local authorities, which deliver things called single outcome agreements. And the single outcome agreements set our programmes of health improvement for the community in Forth Valley. So they're really, really important to me wearing my public health hat, because that's how we set out our programme for improving the health of the population. And that's what the single outcome agreement is about. The chairman mentioned in his presentation that things are not all bad. Actually, things are really pretty good when you look at the public health picture over the last 10 or 15 years. We have started to see significant improvements in deaths from coronary heart disease. We've seen significant improvements in deaths from cancer. Our management and survival from stroke is much better, and that's all very good. It means that we've got a population which is living longer. It means we've got a population that's older. And importantly, it means we've got many more people living with chronic diseases or a degree of disability, and that puts additional loads on the health service and in particularly social care services. So there's a good news story in there, but there's also a significant challenge for us as a health service as we look to provide support to that population. One of the main things that we have to do moving forward, if we're going to cope with that challenge, is to do yet more prevention, to keep making the population healthier, because every pound we're not spending on treating a disease is a pound more we've got to look after that ageing population. So this is really at the core of what we need to do. And I'm just going to show you some pictures in a minute or two, just to bring up 1 or 2 topics that I thought I might discuss with you, just to show you some examples. And it's quite short, because I think I've spoken for long enough. So the things I wanted to cover were really just a short discussion of the work we're doing on immunisation. I wanted to mention early years, I particularly wanted to mention the fact that we now have a family nurse partnership set up in Forth Valley. We didn't have that this time last year, but it's now up and running. And that's a very important programme of supporting young parents in Forth Valley in bringing up their children. The government in Scotland, the Scottish Government, is extremely committed to what's called the Early Years Collaborative, and a programme of trying to make sure that we bring children into the world in the best possible way and we keep them as healthy as possible as part of a programme of turning around public health in Scotland. So the family nurse partnership being in place is a big thing for us. I was going to just briefly mention the improvements in dental health that we've made, because I think they are really very significant. We have a programme called Child Smile, which goes out into local primary schools and nurseries and promotes both toothbrushing and various preventative measures. And it's really important to reflect that we now have a situation where more than half of all of our 5-year-olds arrive at primary school with no evidence of dental decay whatsoever. And it was about 10% when we started, so that's a huge change. And one of the big impacts on that for us as a National Health Service, and it's a good example of the way that prevention can save costs, is that we've halved the number of general anaesthetics we have to give children to take out teeth. When I first came to Forth Valley, we were giving over 1,000 children a year a general anaesthetic to do either full dental clearances, taking all of their teeth out, or taking out significant numbers of rotting teeth. And these children are typically 3, 4, 5 years old. And we've absolutely slashed those numbers through the various programmes that we put in place. And we're doing less than half of that number. So that's a big step forward. Out in the community, we're doing lots of work with the challenges which communities face. And that's things like the work that we're doing on addictions, the work we're doing in helping people to stop smoking. We've delivered over 6,000 healthy 1-month quits now, which means we've got people to stop for a month, and if you've stopped for a month, there's a good chance you can go on to become smoke-free. So that's a really big challenging role, and it involves a lot of our staff doing a lot of teaching, or a lot of support to smokers, but it's really important. We have a very significant focus on alcohol. You cannot possibly have escaped Scotland's relationship with alcohol, and the fact that our communities face many, many challenges because of that, the way we use alcohol in our society. There's a lot of violence, and there's a lot of chronic harm, a lot of liver disease and so on arising from overuse of alcohol. And we have an alcohol and drugs partnership in Forth Valley for the whole of Forth Valley, and we have local alcohol and drugs partnerships in each of our 3 local councils that are working very hard on that. And we've delivered over 12,000 alcohol brief interventions, which are short discussions with patients to help them think about their drinking and adopt more sensible drinking behaviour. So that makes a big difference. And it's good to see that we're making significant inroads into smoking rates overall as a country. And that's obviously due to a lot of national work, such as the smoking legislation, as well as the local work that we continue to do on the smoking cessation programmes. And then the final group that I really just wanted to talk about was some of the prevention activity that we've been doing around cancer. So we have an active programme called Detect Cancer Early, TCE for short, and that's about trying to get in early when people become unwell, because if you can diagnose those conditions early, you can treat more early, you get better success rates and better cures. So in fields like lung cancer, in bowel cancer and in breast cancer, we've had significant advertising campaigns led nationally but delivered by local staff to get people to present early with their symptoms so that we can move in and provide treatment. And that places significant loads on our local services to actually step up the amount of cases that we're seeing, because every time you run one of those campaigns, obviously it makes clinics and testing services and so on comparatively busier. But every step we can take to try and get people diagnosed earlier helps to improve survival. I'm just going to finish off with a few pictures, because pictures are nice. So, immunisation. This is a picture of a recently retired person having an immunisation. And it's important that we continue to immunise, particularly winter flu, but a whole range of immunisations. So childhood immunisation is really important as well. We have extremely good rates of childhood immunisation in Forth Valley. That's largely delivered in primary care, but also through our community health teams, and that's really, really important. This one is my colleague, Dr. Henry Prempeh, giving a childhood flu immunisation. I thought it was nice to show it for 2 reasons. One, because it's the public health team out doing primary school immunisation. The girl in question is called Sophie. That's the daughter of our immunisation administrator, and they're in a primary school in Forth Valley on a Sunday doing immunisations. And Forth Valley has led the way in Scotland in having an innovative programme of doing the childhood flu immunisation programme at weekends in our local schools. What we do is we usually gather the local primary schools and they come to the secondary school on a Saturday or a Sunday, and we manage to immunise almost all the kids through that process, and it's worked extremely effectively. And this year we're immunising just a little under 34,000 children for winter flu, so that's a big challenge. Next one. And just to say, every challenge is also an opportunity, so I thought this was quite a good slide to just as an example, because this is the hall of the school where the immunisations are being done. And the two examples are that's the Energy Saving Trust, meeting with parents whilst they're having their children immunised. We're talking to them about how do you keep your house warm and dry over winter, how do you save energy and fuel costs, and that's really, really important, because one of the biggest public health challenges we face is poverty and fuel poverty. So that's a big chance that we're grabbing whilst we're out there, and we found it's tremendously effective because we've got a captive audience. We do similar things in shopping centres and so on, but people tend to shy away because they think we're trying to sell something. But when we've done it in the immunisation programme, it's worked extremely well. And the one bottom right is just the same thing, but it's the smoking cessation work. So it's please sign up to have some smoking cessation sessions and come and talk to us about your tobacco use. And again, they've had really good uptake when they've gone out to the schools. So every challenge presents an opportunity. I think just the last slide. I've lost my one about the veil of leaving. There was one about the veil of leaving, because I was just going to finish with a few words about the veil of leaving inquiry. No, I haven't. Sorry, it's coming next. So at that point, we're just going to pause. That's a lot you've had. That's a lot to talk about, and we're going to take some questions.
Yeah, we thought it'd be easier just to try and take the questions at each section, and there will be an opportunity at the end as well for people to ask any questions that we haven't managed to cover as we're going along. So, are there any questions on what Graham's raised or discussed with you this afternoon that people want to ask at this point? Could you just say your name and what the question is, if that's all right? Yeah, you get a microphone to speak.
Teresa McNally, I'm from Clackmannanshire, but I'm a retired health practitioner, but also I'm involved in the social housing sector and also on the local PPF or whatever new title we're going to come up with in the community. I think what I wanted to pick up was there's loads of things I wanted to pick up, but I'll just try and... I think it was about the communication. I think it's key to anything and everything that you do, and it has to be two-way between professionals and not only the patients, but their carers and relatives. And I'm just going to leave it hanging there.
I think we recognise absolutely that there's a lot to do in communication, and we discussed some of those issues with some of the patient representatives this morning. It's something you can never do enough of, and it is important, as you've described, that we do it both ways and that we use, and I think Graham's trying to articulate that we're trying to elicit the views of people as we're trying to look at the clinical service review rather than kind of presenting a fait accompli. So at this stage we're trying to gather views so that we have the opportunity to design something which has taken on board what people are telling us. So hopefully we'll be successful in that, and please feel free to tell us if we're not, but we're absolutely, communication is a huge issue for us, and thank you for that contribution. Okay, the lady with the glasses first, and then yourself.
Hi, sorry, I'll keep it brief as possible. I'm not known to be brief, but anyway, thank you for the fact that this lady brought up the fact of patients, because I sit on patients. I'm with neurological groups, I'm with visual impaired groups, I'm with Parkinson's groups, MCN groups, and the thing that's frustrating with a lot of the patient side of it is a patient's pathway and getting information. It's the information that we can't get from Forth Valley. That is a big problem with a lot of the patients' groups. And at the same time, I go to PPF meetings. I don't know if this lady brought this up. I don't know if Jessie Ann's here, but she knows I always talk too much.
She's here yet.
All right. I know I always talk too much, but that's wonderful. But there's never enough time to ask questions to the speakers, because even Mr. Linkston, he was there, and he got a bit of my I hit his jugular at one time. I think it was the first time you were there, because there is never or the pathway how patients can get into Forth Valley to find out about things. This is a problem, and under patients' rights, we've got a talk coming up next month, which is next 2 months, which I think is going to be a wonderful meeting with patients' rights. But at the same time, I'm always negative. Well, I'm not always, but I say what I think with Forth Valley Health Board. But I must give you compliments. After an MCN meeting on the 12th of November, myself and another lady who, she had MS, she's in a wheelchair, and we were stuck in a lift for an hour in the hospital here coming down.
Oh dear.
But the service that we got after it, it was wonderful. But we had to ask for it because we had transport organised on our link-ups, you know, me from Stirlingshire to Clipmannon. But they got us taxis, they got us a coffee, they got us sandwiches because we had medication to take. It was wonderful. But I just hope anybody stuck in a lift would get the same service from the hospital. Because that was always in my bucket list, a bucket list not to want to be. And that was at the top of my, never to be stuck in a lift.
Yes.
So I hope that the hospital will look after everybody the same way.
Okay,
So
I think we would aspire to...
But I'd like to be positive as well for
Okay,
that.
so we'd aspire to no one being stuck in a lift, but maybe Angela could pick up some of the points you've raised. She's our Director of Nursing. Thank you.
It is regarding the patient, the pathway
Sure.
that a patient
Sure.
gets on when they want to find out a thing about their specific condition.
Absolutely, and I know how passionate you are about this, and in fact you raised this last year and we had some discussions, and it's really good to hear that working with Jessie Ann and the PPF you're doing even more around this. I have to say that we have been trying to get this better, but what's been recognised nationally is that we need to do it much better across all systems, because sometimes there's just far too much information. As part of the person-centred programme, and the things that we must do is about making sure that the right information that you need, whoever you are, whether you're a carer, a patient, a family member, is tailored to your needs. And we are looking at that really seriously. We've got lots of really good examples, but I recognise, and again you raised this with us last year, is just as how we get that pathway that you talked about and the information that supports the pathway. And we know we can do it in some parts of the service, but we haven't got it across, and it is an ambition. So, and it's good to hear you're having a presentation on the patient's rights, because it's absolutely needed, and we're going to work together to make sure we do that. And I can see Jessie Ann at the back is nodding, so we'll make sure that we take that forward, and hopefully this time next year we can maybe feature this as part of the presentation to show the work that we've been doing, so that everyone that's heard your question can see that we're actually making a difference. So hopefully that will be helpful.
And also not just online, everything's done online.
Oh no, I know, we need more than online, absolutely.
Somebody's got visual problems.
Absolutely.
And hearing problems, extended problems. What's the point of it? You want to go to see somebody.
Absolutely.
If it's a bona fide thing that you have a problem with, you want to come somewhere and see
Accepted,
someone.
absolutely. I couldn't agree more. So we'll hopefully demonstrate the action next year, because that's the second time you've raised that. So we'll look forward to working with you and Jessie Ann.
Okay, thanks very much for your contribution. Next lady.
Hello, my name's Pat Graham. I've been a carer for over 3 years, and I've been in and out of this hospital on many occasions for lots of reasons. And I also work with a community council along resources around keeping care homes open and all sorts of things, so general campaigning, and I've been an ex-social worker, so I do know the system a bit. Really a question around the whole concept of self-help and public attitudes, people's attitudes towards health prevention. I wondered in what you're doing, is there feedback coming back? Are those attitudes changing in any way, or do they change when people go through crises, or are there different stages in when they might change?
Graham, you can answer.
Just think about that. Yeah, the issue of self-help is really important, and it's something about taking responsibility, I think, is at the core of it. And certainly it does relate back to, I mean, part of the reason I wanted to kind of portray the picture of where we've come in the National Health Service is because we do have a long history in this country of a sort of very paternal approach to the NHS will fix you if something goes wrong. And doctor knows best or sister knows best type approaches. And we are moving forward into a very different period in our history, I think, where people will have to take more responsibility for their own health, but actually want to as well. The facility to do things differently is there. But it takes quite a long time to change those attitudes, and it's also about giving people the opportunity to take responsibility. They can't look after themselves if they don't know how. They can't look after themselves if they don't have the access. And if our systems assume that the only way to get treated is to, go to doctor, come to hospital, and that's the process that people will continue to follow. So we need to have a two-way dialogue with our population about how we actually change things, so people want to take responsibility, feel they're empowered to do that, and can actually make a difference. I don't know if that helps at all. I don't have any specific examples to cite.
I was just about to say, I think empowerment is really important, but from my own experience and lots of others, because a lot of us are over 60, we find that sometimes there's resistances coming from professional people who obviously do want to do their best, but we kind of want to make choices and we want more information. And I would say there's a need for more learning and development in that area, and then maybe there might even be more of a shift.
Yes, and I think that's why workforce is a big part of our 2020 vision, because it's about how we behave. That actually colours a lot of what we do.
Yeah, I mean, one of the opportunities we do have around the clinical services view is to look at some of those points you've raised and try to change the ethos. And I think Graham was trying to articulate that view. So your points are well made, and we'll make sure that they are incorporated as we go forward. Okay, thank you for that. Yeah, Jessie Ann, you need to wait till the microphone gets to you.
Hi, I'm Jessie Ann Malcolm. To those of you who don't know me, I'm the Public Partnership Coordinator for NHS Forth Valley. On the back of Graham's presentation and what Jane and I and Mr Linkston are saying about the Clinical Services Review, I've just completed a round of PPF events in November with various of our professionals giving presentations. But the public feedback, and I feel this is a good time to pre-warn you all, about taking out the actual consultation in it's been talked about January. The public are saying they would very much appreciate if it could be done on a Saturday morning, when, because of the weather, you're not going to get older people wanting to come out in the evening. I mean, I find that with my PPF events, especially in January or February, when we're having the patient rights, and we're actually featuring on equalities as well in February, but also for people who work with young children. We've done this in the past, because I'm kind of old hat and I've been here too long probably, but 38 years with Forth Valley, but basically when we have had consultation events, we had one when we were debating on where the new hospital was to be built. We had it on a Saturday morning in Viewforth, and we had over 250 people turned up. It was a record turnout. So it was really just to pre-warn you if it's hopefully agreeable with everyone. But I personally will be happy to support doing this if you don't mind.
Oh, that's great, Jessie.
Okay. That certainly fits with our experience about the immunisation as well. We were a bit, trepidatious about going out to schools on weekends and thought we'd be invading, but people have really liked it. We found it much more convenient than trying to make an evening or something of that sort.
Okay, thank you. Are there any other questions before we move on to the next section? I'm missing anybody? No? Okay, thanks very much for that. So the next section is about safe healthcare, and so Graham is continuing his dialogue with you for a little minute longer.
This lengthy monologue, apologies for that. It is me, but I shall attempt to be brief. This, however, is a very important part of the agenda, because it's about keeping people safe, and that's absolutely the heart of what we want to do. So we do need to take it very seriously. And particularly in this week when the Veil of Leave and Inquiry report has been published, we thought it was important that we had a section on this, although we would always have had a section on this. And as the Chairman has mentioned, we have HEI as a standing item at all of our board meetings and so on. So it is very much at the core of what we do. So that first point was just to really reinforce that it is at the core of our business. It's not something off in a corner. We look at it all the time. We have infection control teams who are active, who visit all of our clinical areas. Every one of our clinical areas gets a visit twice a month. All of the main clinical areas get a visit at least once a week, and many are getting more. And of course, HAI is not something that's done to people, it's done with people, and it's done by every single member of staff in our organisation. So it's being done every single day. in our organisation. And that's the kind of culture that we've built over many years of activity. Actually, I certainly can't claim any credit for it. It was here long before I arrived. But there's a real culture of infection control and taking safety seriously in our wards, and that's very good, and we want to keep building on that. So it's right from the ward to the board is the words that are being used after the Bell inquiry, and that's what we want to try and build on. There is some good news in the background, in that in recent years there have been significant reductions in a number of diseases, and MRSA and C. difficile are two of them. Multiply resistant Staphylococcus aureus is what MRSA stands for. That's bugs that are quite difficult to kill with normal antibiotics. And again, we've seen significant reductions in those through careful use of antibiotics and through careful hygiene measures. We also screen patients when they come into hospital for these indicated conditions, so that we don't put other patients at risk, and so we can cohort nurse, or we can put people in single rooms and so on. So it's an important part of what we do, that we're alert to these infections and we manage them appropriately. And we have a good partnership out into the community with our primary care colleagues as well, so that we don't admit people with these diseases unless we absolutely have to, because it makes much more sense to manage them at home when they're not a risk to others, rather than piling them all into the hospital where you have that cross-infection risk. So there are a lot of things that we do to try and control infection. We also carefully investigate every single significant infection that we encounter. We couldn't possibly have done that 5 or 10 years ago because there were just too many. But one of the good things about having had this real focus that's got the numbers down is that we're now at a position where just about every single infection, we know the patient by name, we can look at the case records, we can think about where did that come from and how was it managed. We can assure ourselves that that hasn't been a patient-to-patient transmission. And if Leslie Shepherd was talking, she would remind you about what's infection-based precautions, or the standard infection precautions that we use to prevent infection from patient to patient. There is no excuse for a patient in one of our hospitals getting a disease from the patient next door. You should not be transmitting infections person to person. And if we all do the right things, that doesn't happen. And we've had a really good experience in Forth Valley of showing that if we take that seriously, you don't get those outbreaks of patients spreading infection to another patient to another patient. And those things were commonplace in hospitals 10 years ago, and we've had a significant turnaround in that, and that's why the numbers are much lower. And it allows us to take every single infection very seriously and investigate them. So these are things like central line infections or cases of Staph aureus bacteremia, and they get individually investigated so we can learn the lessons. We also very, very closely monitor on an ongoing basis both our performance in hand washing. The system for hand washing has changed. We used to have a hand washing coordinator who did that. It's now a core part of everyone's business in every ward to do regular audits of hand washing practice. And we monitor that. And the reports from those are reported right up to board level to show that our staff are all doing what they should be doing. And indeed our patients and visitors are also following these rules, because it's something we need to do in partnership, and it's what you were saying about responsibility again. We need our visitors to behave sensibly in our hospitals and not to bring infections in, so that's important to us too. So it's all done in partnership, but it does deliver good results. And on the idea of good results, we should just mention the excellent HEI inspection report we got for Falkirk in the summer, and I'd just like to say again, as I've done a number of times, thanks to all the staff who work in Falkirk and who work to support Falkirk to get that excellent inspection report. It's very, very unusual to have the HEI come into a hospital and say there's nothing here that we want to make as a recommendation or a requirement, and it's the first time it's ever happened in a Scottish community hospital. So that was a big achievement, and it's down to staff. And I was speaking to Tom earlier today, and he was saying he was in Falkirk just last week, and it still looks the same as it did when the inspectors came to town, and that's what we need to achieve. So it's not just about getting the report done the day the inspectors come, it's about getting those standards absolutely inherent in everything that we do every single day. So we're quite proud of that. Can we have the next slide? So just a few pictures again, just to break the thing up. This is just hand washing, to remind you that hand washing is really important. This is the Scottish Government's own slide on C. difficile infections across the whole of Scotland, just to show you how things have changed as a response of what we do, and MRSA as well, just to show you the MRSA numbers. A quick slide to remind us of the very good publicity we got around the HEI inspection at Falkirk. And the last one is just a picture of the sign at the Vale of Leven Hospital, because in spite of being quite upbeat about what we're doing locally, that report has 75 separate recommendations drawn from, 5 years of careful investigation, 450 pages of writing. There's a lot to learn in there. And a lot of it was about communication, actually. It's about how we speak to each other. It's about how we share information, and about the attitudes and the values that we bring to work every day. And there's a lot for us to learn in there. So we will pore over every one of the 75 recommendations, and we will see if there are lessons there that we can take forward that help us to keep our patients safe in Forth Valley. That's where I'm going to stop at. I'm going to hand on to the next person, and I think Angela's going to take that.
Thank you, Graham. I'm going to talk a wee bit about the Scottish Patient Safety Programme, and as Chairman had highlighted in his presentation, a little bit around how we're trying to assure some of the most fundamentals of care. The Scottish Patient Safety Programme started about 7 years ago now, and it did initially start in the acute hospitals, and that was because there was lots of evidence that showed if staff reliably done some things over and over again, we could significantly reduce the avoidable harm to patients. And I'm going to come back and just mention a little bit just to cover on the slides. It's really important, and Jane highlighted it earlier, and we've celebrated it a bit today with staff, that the Patient Safety Programme alone has not made care in Forth Valley safe. It has made it safer still, and we have been able to tell you over a few years that the care in Forth Valley is safe, but by doing some things we can make it safer still, and that's what some of the things we're going to, hopefully Graham has started to share some of them with you in relation to infection control, and I'm going to mention a few. But there's a range of things that happen every day with every member of staff that keeps patients safe and prevents harm, and whether it's the care of the older people work, whether it's the dementia strategy, the work we're doing in mental health, the work around anticipatory care plans, or the patient safety programme in primary care, all contribute to that. Our medical record staff are key, our secretaries, and a range of other people that come together to make care safer, and that includes child protection and public protection. So there's a range of things that we are doing. However, Chairman did mention that we were given an award that celebrates how successful Forth Valley has been on its journey around delivering the patient safety programme, which started in acute hospitals and now has grown so rapidly across Scotland and across all of the areas in which people are receiving care in Forth Valley. The mental health team embraced the patient safety programme. We were one of the early adopters and are doing incredible things around managing when patients need to be restrained due to their condition, or really thinking about the types of medication that patients are requiring and making sure that they are therapeutic. Primary care are working tirelessly every single day to make sure that the amount of harm that we can reduce by proper prescribing and administration of medicines, which is a feature through all the programmes. They've had spectacular reviews and progress across that. And again, Forth Valley was one of the early adopters before the rest of the country in maternity care, in neonatal, in paediatrics. And from the very beginning, Forth Valley made sure that although we were looking at patient safety in acute hospitals, that we took them out to our community hospitals, and indeed areas which are classed today as essential, like leadership walkarounds, we've done across Forth Valley from the very start of the programme. So as Chairman said, people got together and voted for our journey of where we are, and we've had lots of successes, but it is a journey and we've still got lots to do, and that comes back to that point that we can still care is safe, but we can still make it safer still. When I reported to you a couple of years ago in the same environment as this, we were talking about keeping people safe from things that we have to use in the environment to make sure that we can care for people, but we don't want to give them an infection. And what's happened in Scotland is that some of those things are now no longer optional. They're not just part of a programme, but they're now called the 10 essentials. And the Scottish Government wrote to the Chief Executive and the Chairman just over a year and a half ago and said, every patient, everywhere, every time, must have these 10 essentials. And some of them Graham's already talked about and we're doing really well on. And he also mentioned the key issue around communication. So the things that the government have said we must do, and we're doing really well, and it's reported to the board, is around hand hygiene, is around leadership, walking around the organisation, making that connection with what's really happening with staff and what are their concerns, making sure that communication that Graham talked about, both in the intensive care unit and happening every single day on wards where people are thinking about what matters and what will keep patients safe that day. We've talked about at our last time when we did this report to you, some of the infections we used to give routinely in the intensive care unit. When I was a young sister in the intensive care unit, I understood that most of my patients would receive a pneumonia because I had to give them help with their breathing. So they had a tube down into their lungs to take over their breathing when they were very, very sick. We knew we were just going to give people an infection. Now in Scotland, that doesn't happen. It has not happened in Forth Valley in over 1,800 days and counting. So we know that there are things that we can do that will keep patients safe, and we have been really successful in doing that, but there's still much to do. The last thing that I've been asked just to briefly mention, and it relates to the Vale of Leven Hospital, but it relates to something that Forth Valley has been doing for some time. And again, we've started on a journey, so we're here, and we've got over here to go to still get this right. The Cabinet Secretary, not the new Cabinet Secretary, but the previous Cabinet Secretary, came and visited Forth Valley just over a week ago, and he did that prior to the Vale of Leven Hospital report being launched, and he had come to Forth Valley to have a look at a system that we have. We have a system that's called Care Assurance, and it's not quite where it needs to be, but it's something that's trying to catch patients and make sure that the proper, most fundamental nursing and caring and comfort care is given every time. We're having some early results around that, and the Cabinet Secretary has popped a letter out asking all of Scotland to develop such systems. So again, it's work in progress. We've still got much to do, but these are the things that are keeping people safe in Forth Valley. I'm handing over to Tracy.
So I just want to, excuse me, I just want to say a little bit about the hospital standardised mortality ratio, which is a complex statistical method of adjusting the absolute number of deaths that are seen to allow comparison between different systems and to look for improvement over time. And in one quarter in 2013, our own ratio was beyond what we would have expected. And that was taken very seriously by my colleagues. There was contact with Health Improvement Scotland, and it led to an extensive piece of work looking at over 110 cases in a structured case note review to identify actions for improvement. I think it's fair to say that hospital standardised mortality is a difficult signal to interpret, and it's quite controversial amongst medical colleagues. But the point I'd like people to be aware of is that this was something that people didn't just say, this is just a problem with the data. They took it very seriously and considered that it might be a signal for areas where care could be improved. And they presented that series of improvement actions to the board, and that's part of an ongoing monitoring plan. Thanks, Elaine. And so this is our current hospital standardised mortality ratio, which is shown as the big blob, and it allows you to see where the other blobs are. They represent other acute hospital situations in Scotland. And ideally, everybody should be within the yellow lines. And it's if you move outside the red lines in this graphical display called a funnel plot that there's a real cause for alarm. So you can see that our big blob is comfortably inside that line. And the improvement that we've demonstrated to date puts us as one of 7 systems in Scotland where there's been an improvement in this ratio since it started being measured of just over 20%. So that's an example of where people have looked at data systematically and thought about other areas that we could still get better, and taken what was probably a relatively weak signal, taken that very seriously and used that as an opportunity to learn more about the system. Thank you.
Thank you for that. So we'll pause there, and quite a lot of issues being covered there. So just, are there any questions for anyone at this point?
Sorry, could I ask just what are anticipatory care plans and the funnel? If people's health is very different in different parts of Scotland. So, I mean, you read things in the press, and I just read the things in the press that say in certain parts, life expectancy is much lower. So could that influence, if you like, that type of graph?
So should I just pick up the funnel plot one first? And what's important to understand about this is that it's calculated on a very, very large sample population, and it looks at the number of deaths that did occur, the observed ones, against those that would be expected, and that's calculated out by a complex algorithm, and so it would be expected that it would adjust for differences in population like that.
Okay, anticipatory care plans?
I thought
Stuart might answer
I thought
that,
I would
no?
like Stuart to, because I've
fine.
mentioned Dr. Cummings, so I think it's only right that I give him he's done an incredible job around this.
I'll just answer from here. Hello, I'm Stuart Cumming. I'm a GP and Associate Medical Director for Primary Care. We've actually done quite a lot of work around anticipatory care plans in Forth Valley, and really anticipatory care plans are where we recognise our more vulnerable patients and where we develop a plan for them with the patient, and it's really a shared plan between the professionals and the patient to look at the options that are available to them. Looking at their condition just now, but also looking at how their condition may change so that people are aware, and also what we can perhaps do to help them, and looking at that on a 24/7 basis.
Could I just ask, does that include deciding whether further treatment's okay, or aspects of, for example, somebody's health deteriorating towards end-of-life care? Does this kind of plan incorporate those kind of considerations? Like if I were a relative, would those be reasonable questions?
Oh no, and that's the sort of questions that we'd like to ask. What we would like to do is we would like to look at what the person's management plan is just now, to make people more aware of the likely trajectory of their condition, what might change, who should be involved in that, and also involving their carers and their family with that. We would share that anticipatory care plan with the patient, but we also would share it with our professional teams. And it also helps us as a sort of group of professionals to actually look at sort of tailoring care to the individual. What we have done in Forth Valley, we have got a system called the Key Information Summary, which means that we can share information about vulnerable patients with other professional groups. So if someone is recognised as being vulnerable, that information can be accessed at the front door of the hospital. It can be accessed through the ambulance service, out of our services, so that people don't have to repeat all their information, and also people have got information about what medicines they're on and what the person's preferences are as well. And I think it's actually what the person's preferences are that's important, because it allows people to determine whether they would prefer to stay at home if their condition was to deteriorate, and also it allows us, as we move towards, in some cases, end-of-life care, to have these difficult discussions, things like power of attorney, and also looking at things like end-of-life care and whether the person would prefer to be resuscitated or not, if they're and have a greater understanding of their care.
Yeah.
Thank you.
Is this only people with like or end of life, or is it a long-term condition? Do you deal with people with long-term conditions, or is it only at end of life?
It's certainly not just at end of life. I think what we want to do is we want to intervene at an early stage. I think what we recognise is that it's important to develop management plans for patients with long-term conditions, so that we manage the condition according to best model practice, but also we allow people to look after themselves as well. So you mentioned earlier on about sort of self-care. So one of the work streams that we're taking forward is around supported self-care, so we're trying to sort of incorporate that within our anticipatory care plans. So I think what we're trying to do is we're trying to intervene at an appropriate stage, so that when people are developing symptoms, we're helping them to manage that condition, but recognising that as people get older, you don't just get one long-term condition. Very often there are other sort of complicating factors, and it's also having a personalised approach. So it's looking at what the individual circumstances are and what their support network is.
Like the idea was, I was at a talk the other week about the yellow card. I thought it was like a football card, a red card, or a green card, whatever it was. A yellow card, and it was about people's allergies to medication, anything you're allergic to, and I says, well, at the hospitals, if you've got a card like a Tesco card, they can scan it and then go, and it's not.
No, I mean, that's something that we need to consider. We don't have the technology just now to support that, but that's something that we could probably look at for the future, and that's part of the sort of direction of travel that we need to be looking at, is actually sort of patients having more information about their own condition and around their own options. What we try to do with and what we're advocating for people with anticipatory care plans is that they actually have a copy of an anticipatory care plan in their house. Now, for some people that's more appropriate or easier to deal with than others, but it does mean that if a lot of healthcare professionals or a lot of social care professionals are going into the house, or someone is going into the house out of hours, then they've got access to that sort of information.
Okay.
In the street, which I've done a few times, you've not got that piece of paper, I've got a card with buttons and whatever on it, because you're registered life, I've got that with me, but it's a card that you could just put, the hospital could scan and say what medication I'm on, whatever. Because I had a makes thing, or not makes, but one of these things, what's the thing that you have on all your medication. It would be wonderful if it could be recorded into
absolutely.
Whatever, rather than go to the hospital, and if you're on your own, you've nobody with you, and you're popped out, and they start asking you questions, and you can't remember this medication, that, if it was all on a card, just put it in your pocket and give them to it, and they could scan it.
That's an excellent idea for the future. What we suggest, and that's an excellent idea. It's not too sensible, it's very sensible. What we have just now, though, if someone was brought into the emergency department just now, and they had an anticipatory care plan, then that's flagged up that person's got a key information summary, so it sort of highlights. Nope, didn't happen.
Okay,
but we'll have
we've got a couple of other people, Stuart. We've got quite a lot of other people, so I'd like to. So no, it's okay. We could maybe take some of the points at the end point if there's anything else. No, it's okay. There's just one or two other people. So
it's more of an observation than a question. Just that obviously it's taken 7 years for the Vale of Leven report to come out. I think the whole culture has changed. I think at the time that it happened, there was a kind of feeling that it could have happened in almost any hospital in Scotland. But we now have the Healthcare Environment Inspectorate, which I think really arose from the experience of Vale of Leven. But it's really just a plea to extend what you're doing already in involving patients and carers in their awareness of hospital infection and how to contribute to cutting it. I know that the sort of hand washing, etc., has been publicised, and I think obviously being involved in a patient panel and having a safety subgroup, I think there's all sorts of ways in which we can be involved even more in helping to cut any sort of infection rates. But as I say, I think the Vale of Leven was a kind of lesson, and the culture hopefully has changed since it has all happened.
I mean, there's a lot, as Graham, I think, articulated. There are 75 recommendations. Some of them we will have, we'll be performing very well against, and some we need to go back and look at. But we are going to, as a board, take all of them extremely seriously to make sure that we don't just assume it's happening, that we are making sure it is happening. So if there are ideas and opportunities for people to input that and information, then we'd be very happy to hear them, because it is important that we make it easy for people to understand what's going on, but also that we are challenged by others about, you know, what we're doing. So your contribution is very welcome. Thank you very much. There's another lady in the middle, I think the lady with the purple, trying to... Thank you.
I just wanted to make one little thankful comment to this hospital. I've got atrial fibrillation and leaking heart valves, which has given me early dementia. And I was able to draw up what I would like at my end of life. I do not want to be resuscitated should I have a cardiac arrest. And that's actually all on the hospital records already. And it's made me feel very happy and well able to live and enjoy my life without the worry that somebody will bring me back when I would have been glad to go.
Thank you for that. Is there anybody else that I've missed in the... No? Okay, thank you. We'll move on to the next section, which Angela's going to start around person-centred care and one or two other contributions, and then we'll take some more questions. Thank you.
Okay, again, I've reported to the annual review several times around patient experience, and for those of you who've been following NHS Forth Valley's progress for some time, you may remember that Forth Valley started measuring patient experience around 2002, and we were the first people in Scotland to do that at that time. I have to say it's something that will never be over for us, and Chairman was quite clear in his presentation this morning that that's at the heart of everything that we do. Also, patients and families and those who need our care don't see the particular difference between safe care and good experience of care. People just rightly expect us to do all of those things together, and we have always tried to make sure that that's always been part of that. You've heard today from lots of our patient and public partners and some of our third sector colleagues, and we've really seen that external look and getting close to us to make sure we're doing the right things all the time and having that challenge just as part as what we do. It's something that Jane and Chairman and others will say all the time, not just at the start of our board meetings, but we need to listen, we need to hear, and we need to take action based on what we have done. And we also then try and work really hard to show people that their sharing of their information results in an improvement where possible. In NHS Scotland, similarly to the Patient Safety Programme is the first time a whole country had tried to make care safer still. And Scotland were really ambitious around the quality strategy and decided that we must be able to capture that and change that culture in the same way we can around patient experience. In some ways, this is much closer to people's hearts. Certainly is really close to mine, and I know lots of people, and particularly people who support us, because if we get the respect and the dignity, we're not individualised about care or something so fundamental that it's a huge issue if we get wrong, people can't readily forgive us for that, but they have worked really closely with us to make sure we can improve that. So what Scotland is going to do, and I'm going to touch on it when I talk briefly around how we manage some of our feedback like complaints, is the whole of Scotland by December 2015 has to make a difference about how people experience their care. And one of the ways that we're doing that, and we're doing it really well in Forth Valley, and there's a really nice example here from someone in Women and Children, and I'll read this bit out if you can't see it. But what we're trying to do in Scotland is implement the 5 must-dos. We believe this is fundamental in terms of reducing the amount of times we get that respect and dignity or care not so good. The 5 must-dos, which this is going to be a really good example of one here, written in coloured pens, of course, because it's Women and Children, it's a children's ward, it's got to be coloured pens. But those 5 must-dos is about what matters to me and who matters to me, and like the point earlier we raised, what information do I need to try and navigate my way through care, or indeed help myself where I need to. Wherever possible, how can the services be personal to me? So we're a big organisation and we have to do things in big scale. Chairman showed some of the sheer amounts of times we're seeing and treating patients, and we have to get that much more about the person being in the centre. So we've got to demonstrate this. And the last one, which is kind of my favourite, I think, and it's nothing about me without me. And I think that really sums all of that up. And what you have here is a really nice example, and I'm having to wear my glasses. I hope we can read this. But this is there's a little bumblebee, and in the children's ward, we make sure that either children can tell us, just same as adults, not just for children, and mums and dads or carers can often help here. But what this youngster has told us is that I like toy cars, they're my favourite things, and his bike is even better than the toy cars. His mummy and daddy, Michael and Kim, and he's got a sister and 2 friends that are really important to him. So that what matters to him and who matters to him. His favourite food, and cover your ears, Graham, is chicken nuggets. And his friends matter to him too. And the last thing, which is really quite astounding, is about being well and being able to breathe, that matters to me the most. And although it's really quite simple, it really helps guide the staff to how you would address the individual, and this is not just for children, but in this case, this young boy, and what we need to do to make sure that experience and the dignity and the personalisation of care is good. I think we've got a next slide. We have a whole range of ways in which we gather experience and feedback. There are national surveys through the national surveys that the government do that focus on the care in GPs as well as care in hospitals. There's been a survey around maternity services. There's this national person-centred collaborative where we come together in Scotland to implement those 5 must-dos, so that in December we can say this is how much centred our care is. There is lots of feedback we get from patients' complaints. We take lots of stories. I think in the last month we've recorded about 7 or 8 different stories, and we're doing that on a monthly basis, and we use them on the board. And we have the patients give us experience all of the time about their local services. We ask patients every time they're in inpatient and outpatient areas how good that service was. And we have lots of work through the patient opinion, which is an external web-based site, and through media, through Elspeth and the communication team, people are telling us through our websites how well we're doing. The next slide. This shows briefly the most recent national inpatient survey, and we've just shown you a few things here about what Forth Valley did well and what are our current areas for improvement around this. The most significant part of this is an external survey. It's sent to people's homes. There's lots of reminders. We had just less than about 500 people in Forth Valley who had recent care across the inpatient services who reported back, and we had the most significant improvement of any patient experience scores across Scotland. So it was an area we wanted to do better each year on, and we've managed to do that. But the other messages I gave around safety, there is still much to do. The patients and families were telling us some of the things we do well was particularly around A&E. We had some amazing figures from our staff around A&E, and our general manager and our staff earlier were in the room who received an award. They're saying the information people get before they come into hospital is getting better, and it helped to know what was going to happen. And again, some of our patients and representatives today have raised that. They said they thought they had enough privacy in our areas, and there's this sense of our toilets, bathrooms and clinical areas being clean. The things we have to work on, and these scores were still pretty good, but these are our areas for improvement, and some of them have been pretty consistent. So we need to be much better at helping people to have a real information around discharge. And patients are still bothered by noise in hospital. In the middle of this column here, there is a new section which comes in the back of some of the work that's been done national, and we're asking patients if things did go wrong in the hospital, were staff open? Did they tell you? Did they involve you in any investigation that you may need to do to make sure that the hospital or the organisation has learned? They were new questions, so we've never had them before, but again they signal this duty of candour or openness that we're trying to make sure happens across Scotland. And I think on my last couple of slides, just a little example, Helen mentioned patient opinion earlier in our patient and public panel session. What we have done in Forth Valley is a range of ways. There's not enough ways in which we can't hear what people are saying about our services so that we might understand what matters to them so that we can make improvements. This is just one external site that we use. All of the feedback we get from this, like everything else, is drawn together and we feed them into our action plans and make those improvements. And the last slide, because we've got a range of feedback from all sorts of Facebook, Twitter, media, people just coming to front reception, people just phoning or contacting the website, and we want to continue to encourage that. I think I've mentioned throughout the short presentation in that every single time we get feedback, we make sure we take action. Sometimes we have to just understand that it was a context, it was an experience, it was a human relation, people not quite gelling together, and we're working really hard to support our staff who do an amazing job, but we don't always get it right. The rest of it is fed into action plans in the organisation and they drive improvements, and we can see over time where we're getting things, doing things really much better, and infection control has been a really good example of that. Just last couple of comments from me. Again, I reported to this meeting a couple of years ago around our performance around complaints. I think we've been really clear about how seriously we take complaints. It is really important that we have a system where people can reach us easily, but we do think that there is more that we can do using examples like patient experience and the 5 must-dos to try and perhaps not have some of the complaints that don't need to be there. And we're going to work really hard with local resolution, and that goes back to the Patients' Rights Act, to make sure that we're doing that. Just hearing feedback all of the time, in real time, and making changes for patients and families. So we're working really hard around that. But there are times where people feel we have got it significantly wrong. And I think I've said through my 2 sections that we do lots of things well and we get lots of things right, but there is no doubt that there are times that we need to do better, and sometimes we don't get care the way it should be, and we all accept that. Everyone every day is trying to avoid that, but often we get it wrong. What we have done around this process is worked really hard to make it much more accessible. If we can't deal with it in a local resolution, and work really closely, we're taking a person-centred, patient-centred approach to families and people who need to tell us that we didn't do very well. And that's been significant over the last 2 years since I've spoken to you. What has been significant, and again, the Chief Executive has been so supportive with the General Managers and the rest of the Executive team in making sure that we can respond much quicker with even more quality and candour, as well as action, and explaining why we think we got things wrong for families. And we've had significant improvement within this year, which has moved into this new year, because we're in since March. Our performance is much better. We're still seeing a high number of complaints in Forth Valley compared to boards that are similar size. But the really good news is that the complaints about our health services across Forth Valley, they're reducing, and we're hoping that's because our patient-centred work is increasing. We do have 3 prisons in Forth Valley, and quite rightly, the prisoners who are receiving health care use our complaint system to let us know when health care hasn't been good. And with 3 prisons, what we've seen is a rise in our complaints because of the amount of prisoner complaints. But again, as you would expect us to do, we're working with the managers, with Cathy and her team in the prisons, to make sure that we can be person-centred to those prisoners needing health care, and perhaps find a different way rather than using the complaints system. So it's a key focus for us. We're doing well in some areas, but we're really working hard as an organisation to try and reduce those complaints which we think are unacceptable around attitude and behaviour, trying to improve particularly around communication, or where we've got something which is so fundamental to care wrong. So doing well, but more to do. It's been the message of my 2 presentations.
Thank you. So I'm just going to briefly cover our waiting times. You heard the chairman say at the beginning of the session that was an area where we had struggled. And we've made significant improvement, but as Angela's just said, that we have still work to do. So I'll briefly take us through that situation. So in terms of inpatients and day cases, we are required to treat people. There's a legal guarantee called the Treatment Time Guarantee, sometimes referred to as TTG, which requires us legally to treat people within 12 weeks. And I think we've had a very positive experience of that, and we've had a very, very small number of people who have waited longer than that for the inpatient and day case treatment in the last few months. And so that we regard that as a significant improvement, and we will continue to do that and try to continue to reduce that even further. But at the moment we're maintaining that. In terms of outpatients, we have struggled with that. There is a requirement to deliver outpatient treatments within outpatient attendances, for a new outpatient within 12 weeks. We had a very large number of patients waiting well in excess of that. That number has reduced significantly in the last few months, but there is still work to do in some specialties. Significantly within audiology, we had a huge number of patients waiting longer. Now we've got a relatively small number, less than 100 waiting more than 12 weeks. However, we're not complacent. We would like to get to reduce that further, and so there has been a huge amount of work. But the team have redesigned audiology, and that has been a transformational change in the last wee while. So that is a significantly improved waiting time for the board and for patients waiting for that service. The second bullet point there talks around some of the areas where we still do have challenges. Orthopaedics and ophthalmology across the whole country have been difficult specialties to manage the demand and to therefore maintain the 12-week guarantee, and we are no different from that. However, we do need to make sure that we have got that enough capacity to ensure that patients are waiting for those outpatient appointments, and we're actively working on that just now, but there is still work to do there. And within mental health, both child, adolescent and adult services, we have had some challenges around reducing the waiting times, and we're not yet delivering the required level of access to those areas. However, again, we have invested in significant sums of resource in that to try and improve that, and we're about to advertise for some further staff to reduce those waiting times. So those areas are the areas where we do need to focus in the next few months to reduce further. In terms of diagnostics, the main two areas which are looked at are imaging and X-ray, which the time is six weeks for that, and we're delivering that routinely. However, in endoscopy there has been an increasing demand, and we have struggled to deliver a 6-week waiting time for endoscopy, both for routine first endoscopies and also for return patients. So we have significantly invested in that, but there is still work to do. It is improving, but there is a lot of work for the board to do in trying to improve that further over the next few months. Graham touched on his presentation on cancer, and for those of you who are familiar in terms of the diagnosis to treatment and the referral to treatment process, they are discussed as the 31 and the 62-day target. The ins and outs of that I won't go into just now, and I'm happy to take any questions around that, but suffice to say this board has given that a top priority and has, for the very most part, been able to deliver the 95% required in both of those targets. So the performance around cancer weights for this board has generally been very good. Not to say there are not some challenges, and it is an ongoing debate around those patients, but it is important, and I absolutely recognise that for patients who are on that journey, time is very, very critical, and it's a very anxious period for people. So we do have to give that a top priority, and we're continuing to do that. So I think it's fair to say in waiting times we've made significant improvement. However, we're not complacent, and there is still a lot to do. So I'll hand over to Tracy now, who's going to talk to you about some of our accident emergency and access there.
So access to care in an unscheduled way, whether that's in hours or out of hours, has remained a challenge for us. So our performance against the 4-hour standard, there have been many days when we've achieved 95%, but many days when we haven't. And it's that level of variation in the performance that we have that we need to work on now. So we have done some things to try to improve that. We've established a frailty clinic so that colleagues in primary care, if they see somebody they think is suitable, can arrange for that person to be seen and assessed in an outpatient setting the same day or the following day, with the hope that we would avoid admission, particularly for older, frailer people, and because we know that when they are admitted to hospital, even for a short time, that can be very destabilising. And we are starting to see some benefits from that frailty programme. We heard this morning about a fantastic experience that a patient brought up that they had had from our out-of-hours primary care colleagues, where somebody had made several phone calls to follow up to make sure that the care that they wanted to see put in place had had the right effect. And I just want to use that to acknowledge the hard work of staff in the out-of-hours service. And then we also saw the emergency and acute assessment team receive their Team of the Year award in the staff teams. I just want to acknowledge for these staff working many hours outside the normal working week in quite pressurised systems. It's important that we acknowledge all the hard work that they've done, even though we haven't managed to achieve the target every time. So we still have work to do in making sure that we are reliable in the system that we're offering, and that includes exploring other options within the community, such as the Bowness Community Project, about ways that we can give people advice or information about services that are there, in the hope that they will not need to attend our hospital services in an unscheduled way, that if they need an appointment, that can be arranged so that it's done in a planned way rather than in a very disruptive, unscheduled way. Thanks, Elaine. The next thing I just want to touch on is stroke care, because I think this is an area where we've seen significant improvements in the way we've delivered care. We are now meeting the required elements of the bundle of things that we know make things better for care for patients who have a stroke in 80% of the patients. And this is just one element of that. And this is just to show you some numbers around the number of people who have a CT scan undertaken of their brain in the right time frame. So there was a change in the way this standard was measured, and that's why you see the black line is from the old way of measuring the standard, and the red line is for the new way of measuring the standard, which would be that 90% of people get a CT scan within 24 hours, and you'll see that we're clearly achieving that. And I think we will all be able to understand how important it is that where we suspect that's the diagnosis, that we get to that diagnosis in a quick time frame, an appropriate time frame, so we can tell people what's happening and what the treatment plan is. So I think we have seen significant improvements in the way we've delivered stroke care, so I wanted to share that with you.
Okay, thanks very much. So are there any questions on any of that people want to ask? Okay, later.
I wanted to do a positive on the cancer care from the hospital side through into the community. I experienced a good friend of mine who died but used the services this year, and I cannot say, I mean, it was so positive for not only her and her family but her friends. So I just wanted to do a positive there for all staff at all levels, both acute and community. But the bit that I'm concerned about, and I thought I should take the opportunity to raise it here, is the boarding out. And I still think that is not appropriate, especially for elderly patients, specifically with dementia. And I know you'll all be aware of that, but I recently had an experience of that with a friend of mine, and I just think the practice should stop. And if the bed blocking and the boarding out is because we haven't got sufficient beds across Forth Valley, then maybe that needs to be revisited.
Okay, Tracy.
So absolutely recognise that what you say, that boarding is not something we would want to see happen. It's really a symptom when it happens of flow across the whole site not going according to plan. We are doing a big piece of work with some national partners to look at flow across our whole system, and I would hope that that would be a way to reduce further the number of boarding days that we have. We do have quite clear rules around when we do have to board, which is not what we should be doing. We do have quite clear rules around the types of patients who we shouldn't be doing that to, which would include people with cognitive impairment. So I'd be happy to pick up with you afterwards what happened to your friend to address, to make sure that was sorted out.
Okay, thank you.
Yeah, no, I was just indicating that, Teresa, it would be good to hear that, but Tracy's obviously offered that, and we have got strict rules, as Tracy said, and we've also got particularly around cognitive impairment, we have a butterfly system, which really to move somebody with dementia is not something we would expect. So I think we would want to, just as Tracy said, hear that experience and really learn from it. We've got systems in place to try and prevent that. So again, we would take that away, and thank you for that. Thanks for sharing that with us.
Any other questions? Okay.
It's kind of linked into maybe public health and self-awareness. Where would requiring the services of a dietitian that links into lifestyle, and people have had operations and then they've got to make some lifestyle changes, when they go back, does that fit into outpatient, or is that with GP services, or is that?
I don't know whether my public health experts, and I think every one of our staff, and we've had some good feedback recently, but every one of our staff are looking for those health improvement opportunities, and there is the routine referrals to dietitians and other things, particularly around their clinical care, but similar to the brief alcohol interventions and other things, all of our staff in every aspect are trying to do that. And one of the things, particularly even around the agenda around health equalities in relation to people with learning disabilities, or we had colleagues and people with learning disabilities who won an award earlier, and they are providing information and leaflets that support people with a learning disability to make choices. So we've got a range of things happening across public health, and all of our staff are looking for those tobacco instance, the diet, the lifestyle, stress management, and indeed we support staff, which you will hear from Helen soon, around that very area.
Okay, thank you. Anything else? Have I missed anyone? No? Oh, sorry. Gentleman over there.
Thank you. Hello very much. May I suggest that in future these meetings, that the questions be left to the last. As a former chair convener of many national organisations, it completely ruins the whole afternoon. It's nearly 4 now, and we've all got other things to do. So could I recommend that questions be left to the last? As I have to go, I'm going to be impertinent. Mr. Chair of the board, the buck stops at your table when there are inefficiencies over the Forth Valley Health Board. I'm not going into the Vale of Leven, which was an absolute outrage, and I hope people will be held responsible and called to court if necessary. Mr. Chairman, I noticed this morning from your website, you were speaking about a positive experience in health. Now, this morning I noticed on your board, your website, there are, as at 6 o'clock this morning, there were 35 vacancies across the Forth Valley Health Board, ranging from doctors, consultants, auxiliaries, etc., etc. What are you doing to sort this out? Because I noticed some of the positions, they have to be in by today or the 5th of December. We cannot get a positive attitude and treatment if this is the case. And I notice this is continued over various months, by the way. And if you've got, from your report, page 22, you have a total of 1,080 complaints were received, an increase on the year of on the year's total of 689 before, which is nearly 400 more. It's no use saying, Mr. Chair, that this represents a very small percentage. The fact that it means that over 1,000 complaints were received by your departments, which means it could be 4,000 or 5,000 people in families were involved in this. And I know from my Westminster and Holyrood experiences, we live in a particular bubble, and so does the National Health Service. In fact, I don't know why the National Health Service is treated as a sacred cow that it has become. The point is, those of us who are living in bubbles have to get outside and see what's going on with the ordinary man and woman in the street. Now, there is dissatisfaction about your performance. There is satisfaction about what the basic you're all trying to do, and I shall be there to support and do that. But let's be complacent, and if there are errors and mistakes, let's get on with it this coming year. Thank you.
Well, I can assure you we're not complacent, and that's why we are speaking to patients to find out about their experiences and acting on that. So we are not complacent. So I can't accept that as a criticism. In terms of the vacancies, do you want to cover that?
I mean, you've covered a number of issues there. I mean, I think Angela has answered the thing about the issue about number of complaints. Every complaint that we take, and Angela showed a slide which showed that we are looking two things. One is that our routine healthcare complaints are reducing, and I've asked the team to look at a 20% reduction in complaints to make sure that we're actually dealing with that. What we do have to do is engender a culture where people have got concerns and they raise them at the time, and we are locally trying to resolve them so people don't feel they have to complain, because it takes a lot for a patient to complain, and I recognise that a lot of patients are still in the system and don't want to do that, but actually what we are looking for is satisfied patients and families and carers at the time. So we're spending a lot of time looking at that just now, so I would assure you there is absolutely no complacency. We've shown a huge improvement in the time we've responded to complaints, and we're now focused absolutely on reducing the number of complaints and making sure the service at local level is sensitive to respondents. You raised another issue around vacancies. We, as you would expect, at all times will have a number of vacancies. People leave all the time, they retire, they leave, and we look at each post and ensure that quickly vacancies are advertised if it's appropriate to do so, and that Helen and her team are working to probably a 12-week turnaround at the absolute maximum to return that. There will never be a situation where we don't have vacancies. That's just the way it is, and every board in Scotland will have vacancies. But I don't actually think 35 vacancies, with due respect, is a huge number for us. What it is important to do is make sure that the services are covered at the same level for patient safety and quality while those vacancies are being filled. So we're trying to do that, and I would be happy for Angela or the medical director, Tracy, to pick up with you any particular instances you've got of things you're concerned about, so that we are able to take on board your specific points if there are any. I think in terms of the questions at the end part, I think we are conscious of trying to get over to a large number of people, a large number of issues, and therefore to hold all that to the end, we made a judgment that it would be easier and better for people to actually ask us things as we're going on, and we will take a summary of anything else at the end. So that's a judgment we've made, I'm afraid. So, okay. So happy to take on board any of the specific points you have with Angela and Tracy, if that's all right. Okay. Is there anything else that people want to raise on this section? No? Okay, if we could move on to the staff section, Helen, please. Thank you.
Okay, yes, I'm conscious of time. I'm going to pick up this year, as I do every year, the topic of staff engagement and staff governance. And as we've heard throughout our discussions this afternoon, delivering high quality services and improving health and healthcare absolutely requires a confident and a skilled workforce. And we know that research tells us that a positive staff experience leads to a positive patient experience. So for me, it's about giving an assurance this afternoon that as a board we are committed to developing, to supporting, to listening to and engaging our workforce. And just in response to the gentleman who spoke earlier, we have low turnover within our organisation, and we have very successfully attracted to all of our vacancies over the last year, and our feedback from our staff survey shows that our staff consider NHS Forth Valley to be a good place to work. So we are in a good position in terms of continuing to attract staff to be able to deliver the services that are important to patients and to communities. As I said, we want the experience of our staff to be positive, and we want it to be positive so that our staff can deliver the highest quality patient care and also create a great place to work.
We want NHS Forth Valley to be a very good place for staff to come and work. That's important to us. We've heard about new ways of working, and it's easy to talk about new ways of working, but actually it requires a workforce that is willing to do things differently, to be a voice and advocate for patients and for communities, so that things can change and that we can deliver modern services in a way that people want. Our responsibility as a board is to make it as easy as we possibly can for our staff to do great things every day. And we were fortunate earlier on today that we were celebrating so many achievements across all of our organisation. High standards of care are in large part due to positive relationships, and we benefit in our organisation from a very strong background of close partnership working with trade unions and with staff representatives and with our staff. And as I've said, our staff's willingness to work in different ways, to be patient-centred and to work in multidisciplinary teams. We continue our commitment to staff governance, and within the NHS in Forth Valley, staff governance is equal to and as important as financial governance and clinical governance. And I think that's a really positive asset that we have, that the voice of our workforce is heard at the heart of the board and is central to all that we're doing. This year, with our trade unions and others, we've updated our local workforce strategy, and we've ensured that it's aligned to the Scottish Government priorities. And you saw earlier in Graham's presentation the Everyone Matters document that our Scottish Government colleagues have published. At the heart of that is about staff engagement and about the question that we've heard earlier from Angela in asking patients. So it's about asking our staff, what matters to you? What will enable you to do the best job possible? What they've said to us is it's important to be part of an organisation that's open, an organisation that's honest and that it's ambitious, that it has a caring and confident leadership who value their staff and enable people to work in a way that does the right thing for patients. We've sought to respond to that, to listen, and we've developed a staff experience and engagement framework, and we've developed that closely with our staff side colleagues. One of the elements of that was the reintroduction of a staff recognition scheme, and the buzz and the excitement and the energy that was felt today in that event, I think spoke volumes for the commitment that our staff across all our organisations show every day. We have a staff engagement and communication schedule, and we're hearing the comment earlier about we can't have everything on the internet, it needs to be in paper too, so we've sought to be very clear that we have information on the internet, but we have paper documents. We create newsletters which are able to be read quickly and easily and aren't turgid. And that was important feedback from our staff. And we have a staff news that has within it a section that is about Everyone Matters. The board this year has also introduced bi-monthly meetings with various staff groups coming along to showcase their work. So there is a direct correlation between the board and the staff who are delivering care. And of course, we meet regularly, both formally and informally, with our staff all of the time. We heard from Graham too about values, and we've put a lot of work into engaging with a great many of our staff to develop values that link to corresponding behaviours, so that we understand that teams are able to self-assess, agree changes and put in behaviours that allow teams to be successful. We've refreshed our dignity and respect policy, and that's been about a focus listening to our staff on early intervention and prevention as priority skills when dealing with sometimes quite difficult and challenging situations, and we've put in place training to support those challenging conversations. A piece of work that we've done this year significantly is about our knowledge and skills and personal development planning. We've made significant progress, but there is definitely still work to do there, and we have put in place an improvement plan so that we can ensure that staff have high quality, meaningful reviews that allow their personal development to be priorities for managers and teams. We've also put our top 10 corporate mandatory training topics online to alleviate many of the access issues which our staff have told us about. And we continue our commitment to a wide range of leadership development, again responding to that priority from our staff that we need to have caring leaders in our organisation. Importantly also, we've reintroduced staff long service awards. That was considered to be something that our staff saw as very valuable and complements the staff recognition. We have people who have in December the opportunity to celebrate 40 years service with NHS Forth Valley. That's a wonderful achievement, and again says a lot for the personal development opportunities and that NHS Forth Valley has proved to be a good place to work. Externally, I've been very keen that we have our Investors in People programme continuing, so that we have external assessment, so that we're not just looking internally at how we're doing, but we're having others coming in to assess and make sure that the work that we're doing to support our workforce is appropriate. I'm going to pause there on the topic of engagement before I go on and talk about attendance, if there's anything that anybody would like to ask in relation to that.
One of your problems last year, just prior to Christmas at this time when I was in Greens, your staff were wonderful, bottom line staff, nurses, whatever, were wonderful, but the problem was that a lot of the grievances with the nurses on the wards was about Christmas transport, Christmas Day transport.
All right.
Where they were having to pay. There was one person, particularly from the health groups, now £40 for a taxi coming and going, and I said it's a voluntary Christmas Day, no, it was compulsory. So why don't you put on transport, bus transport, or whatever, for staff on Christmas Day?
Well, that's a new one on me. I can honestly say that's...
I was 5 days at that time, and that's what all the staff were talking about, Christmas time and the fact who was on duty and the transport, that they didn't get transport in.
Right,
Okay.
Let's look at that.
But I thought, why can't they have put in a bus from one area to another, let them get to the bus area, but not £40 a taxi from the hill groups to Forth Valley.
Okay, and thank you. I'm sure the staff will be delighted that you have raised that issue.
And another problem was with the fact that corporate staff can get a reduced bus fare from Falkirk area, but not the Stirling area. They can't get a reduction on the buses from Stirling to Forth Valley.
Now, I'm going to give you a very quick response to that, and that is to say, no, I'm just, but just because I'm just going to say really quickly, we have a gentleman in our organisation by the name of Mark Krask, who is our transport manager, and he is a guru on how to get to the best places quickly and at the most cheapest cost. So I hear exactly what you're saying. Your colleague beside you were you wanting? You're okay. Right.
Okay.
Okay.
Right. Okay. Well, I'll move on to.
Okay, let's keep going.
I'm going to move on then to health and well-being. So the health and well-being of our staff is obviously very important to us, and we've got a wide range of well-being campaigns, policies and terms and conditions designed to ensure that our staff stay safe and well at work. This year, as in each of the previous years, we've retained our focus on staff attendance at work. However, the 4% standard remains a challenge for us and therefore remains a priority. Our approach to attendance management remains a single system approach, which is very much supported by our staff and by our trade union colleagues. There are areas which routinely achieve the standard and in fact exceed the standard. However, there are areas in our organisation which do not achieve the 4% standard for attendance, and our focus is on these areas. Our average attendance last year was sitting at 5.13%. This year we've seen improvements in the first 3 months of the year where we were below 5%. However, there's much to do still in relation to achieving a 4% attendance level within our organisation. In addition to ensuring a fair and consistent application of our attendance management policy, we've been learning from other employers about their approach. And as I said earlier, we've adopted a What Matters to You approach to have conversations with our staff in groups about the issue of attendance and what ideas and suggestions they can come up with to help us to tackle this. This actually achieved national recognition earlier this year, and we received an award at the NHS conference. We've been building on this approach, working within particularly our facilities workforce group, and indeed recently we saw a significant reduction in absence levels in facilities. Our challenge, however, is to maintain this. We're also very aware that in modern life, pressures and coping skills are very much the forefront of our staff's thoughts. Stress, whether from home, personal life or work, is an issue, and we're working hard to help our staff develop coping skills to understand and manage these. And we've run a number of very well attended and well evaluated courses, and we're continuing with that programme of work. Particularly within our community health partnership, we have had very positive feedback in relation to the stress management workshops. And we will continue to work hard and listen to support our workforce. We've also introduced, just finally, in relation to attendance management, a mid-year action plan, which sees us linking with our GP colleagues to ensure that they are aware of what we can offer to our staff who attend local GP practices by way of rehabilitation programmes and early supported return to work where that's appropriate, so that staff can be back at work in a supported environment, doing that which they want to do, which is deliver healthcare either directly or indirectly. I'll stop there. Thank you.
Thank you. Any other questions that people have had answered? No? Okay. So the next topic we're going to cover is just a brief update on where we are with health and social integration, and Cathy O'Neill, the General Manager of the CHP, is going to just speak to that. Thank you, Cathy.
There's obviously a few people need to go. I won't take it personally. Afternoon, everybody. I'm Cathy O'Neill. I'm the General Manager for Community Health Partnerships, and I'm also supporting some of the work to take us forward into health and social care partnerships. Delivering high-quality healthcare in Forth Valley increasingly requires us to work in close partnership with our 3 local authorities and with the extensive range of voluntary and community groups that exist across Forth Valley. Patients with very complex needs or lifelong conditions don't have needs that easily separate into either healthcare or social care, and the most effective support is that which is well coordinated, seamless and person-centred across those services. There are, in terms of the work that we do with our partners, we have very good examples of where we have built built partnerships and collaborated well. Graham mentioned addiction services, where we have a very strong partnership with local authority, third sector, particularly Signpost, and the addiction counselling service to ensure people get direct access to help for drug and alcohol problems and to get fast access to treatment. And it's only because we work really well with our partners that we can maintain our 3-week referral to treatment target. We have a long-standing arrangements for joint delivery of mental health and learning disability teams in the community. Our community staff, OTs, physios, district nurses are working closely with social care services to deliver rehabilitation and reablement in people's homes, in day centres and in in residential facilities such as Ludgate and Tiggett's Hall, and in Allen Lodge in Stirling. Now, this means this is focused on reablement and rehabilitation. They're just fancy names to focus on working on the assumption that people who have been ill can recover and can do all the things that they did before, rather than thinking that they can't do things, so we have to do things for them. And that's what reablement and rehabilitation is all about. Sporting discharge from hospital has been mentioned already today, and really important that when people are recovering from illness, we get them home quickly as possible, because we know that that recovery is best done at home or in a homely environment and not in a hospital environment. Social prescribing, we have been working very closely with particularly the voluntary sector and third sector partners to develop these types of projects. And social prescribing just means that GPs and other health staff are able to refer people to non-medical or non-NHS services to help them with their problem. Exercise referral to the peak would be a really good example of a social prescribing service. And we're working with Stirling Council to develop a joint and integrated care hub, which will enable us to use our health beds and social care beds in a very flexible way, and to use our workforce in a flexible way to meet needs as they will change over the years. Just a couple of examples just to kind of illustrate what we've been saying. Sporting early discharge, this is a new service that aims to identify patients early in their stay in Forth Valley Royal who may benefit from coming home early to have the assessment of their ongoing needs done at home rather than in the hospital. So this involves hospital managers, it involves community nurses, it involves the community rehabilitation team, and it involves social care. And it's a coordinated response to getting people home early. And we're also undertaking, there's been a lot of talk today about anticipatory care planning, and so we also undertake anticipatory care plans that nurses undertake. And this is about looking at somebody's long-term needs and trying to make sure that people are able to stay at home, and we reduce the need or the potential for readmission to hospital. And I'm just going to tell you, this is a nice example of a case. This is based on a real example, and this was about Bob and Kath and how we've helped them to stay at home. Bob had serious lifelong problems, and that in recent times required Bob to come into hospital, lots of admissions to hospital, and over the last 6 months or so, the longest time he'd stayed at home was 10 days. His wife Kath was desperate for him to stay at home. They wanted to be at home and she wanted to look after him, but she was finding it increasingly difficult. So when when his health deteriorated, he would come into hospital, he would come back home, and then the whole cycle would happen again. And Kath was finding it increasingly difficult to cope. So how we helped? Our anticipatory care nurse met with Kath and Bob and asked them, and we're using a technique called what makes life good for you. So it's a conversation which doesn't start with what are all your problems, and doesn't start with what their health problems are, starts with what is it that will help you, what is it that you want out of life that we can help you with. And they said that they wanted to be at home, they wanted to have a routine, and they wanted to go shopping and have some days out. So the anticipatory care nurse worked out a plan with Kath and Bob. They brought all the teams, the health care teams and social care teams together, and they made a plan. And they planned the discharge from hospital, and they talked to the family, and they went and they did home visits, and they wrote a plan that I think that Stuart talked about. They wrote a plan that was at home, everybody knew about it, and they shared that plan with everybody who mattered, and they told people what to do if Bob's condition deteriorated, and they helped his wife to understand what would trigger that. So, and they also helped Kath to, as a carer, because that's really important that her health was supported as well, and they also helped to increase her welfare benefits. So the outcome of that is that Bob has now been home since August, and that's the longest period that he's been able to stay home all year. The other example, that just to mention, is not my example, it's a Falkirk and District Association for Mental Health example, where they are delivering a pilot social prescribing service. Now we quite often think about social prescribing as about physical health, but this is actually about supporting people's mental health and well-being. And that's providing time to listen to people and to connect them into social opportunities, rather than only thinking about a medical solution to problems of mental well-being. And GPs really like this service, and they want it to be expanded to all GP practices in Falkirk. We want to do more of this. This feels like the right thing to do, and people tell us that this is the right thing to do. And we need to do more of this, and we need to do it on a consistent basis. And the vehicle that we will use to do this is health and social care integration. And this will put our partnership working, which is constantly developing, but it will put it onto a more formal legal basis. So from April 2015, there will be new legislation that will establish health and social care partnerships for all adult services. And there will be 2 partnerships in Forth Valley, a Falkirk partnership and a partnership covering Clackmannanshire and Stirling. Now, I asked some of my community staff to think about a before and after. What does it feel like now, and what do they think the integration, how will that benefit? And that's what they said. They said that they believe that integration can help with the single point of contact, and we've talked about that a lot, and patients tell us all the time, we don't know who to go to. If only we had a single point of contact who could help us, because we find it difficult to navigate the system. It's too complicated. So they think that will be helpful. They think that it will support a smoother transition from hospital to home, and we've seen that example with Kath and Bob, where that was a very smooth transition. They think there will be more consistent messages, so that health staff and social care staff will be closer together, and hopefully we will be giving a consistent message to people. And that will result in a more positive experience. And support can then be coordinated and planned on an ongoing basis, rather than often feeling that it's fragmented and it stops and starts. It can be more planned. And ultimately what our staff want is to have the right service in the right place at the right time. So our staff believe that integration can and will deliver that. Just finally, how can you get involved? Over the next year, there will be lots of planning and lots of preparation for these new partnerships coming into place, and we will have to have all the arrangements in place by the end of March 2016. And it's really important that we get everybody, as many people as possible, involved in planning that. And we will have to develop a local, for each of the 2 partnerships, we'll have to develop a local plan, and that plan will need to take into account the needs of localities or local communities, so to understand the different needs of local communities, and it will also need to take into account the needs of different care groups, so people with a learning disability, people with mental health problems, the needs of older people who've got very complex needs, and people who have disability, and it will need to reflect all of that. So you can get involved in that. There will be lots of opportunities to get involved, and lots of opportunities to give feedback on the plans as they develop. Also, there will be formal structures that will support these new partnerships, and members of the public who are service users or who are carers will be able to be represented on the planning groups that we will set up, and also on something called the Integration Joint Board, which will be the governing body of these new partnerships, and there will be representation on those as well. So opportunity for you to get involved, and please, particularly in relation to the plan, is a really important thing that we need to get right, and we need to make sure that we shape that and that we're very clear about the priorities and what we want these partnerships to do. So please take the opportunity to get involved. Thank you.
Are there any questions on that? Integration is a huge issue for the board going forward. Anything people want to raise?
Can I just ask, does that mean there's going to be a significant shift from the use of, say, residential care homes to a lot more people staying in the community? And is that where the financial resources will go as well to kind of support people?
Well, certainly the shift is to supporting people to stay at home, if possible, or in local homely environments. And residential care homes or care homes will be part of that spectrum. But sometimes what we've seen in the past is that because we haven't taken time to offer people reablement and rehabilitation, we've not given people the opportunity to see whether they could go back home. We've made decisions too early, so people have gone into care homes because people have thought that's the only option. So the idea about getting people back home to assess them gives people the opportunity, as much opportunity as possible. It might be that they still have to go into a care home at the end of the day, because that's the best thing. But yes, you will see, I think, a shift across those community resources.
Any other questions? No? Okay, thank you for that. Shall we just move on to the financial position, I think? Move on to that, thank you. Fiona?
Thank you.
Going to do it.
I could be really, really brief and say 13-14 achieved, 14-15 on track, and 15-16 challenging. End of story.
Definitely a gold star.
But I just want to add one bit, so we've got one extra slide. It was really more the bit to connect a bit about going forward. We do get an increase in resource. It is small, but we do get an increase in our resource each year. But the demands that are hitting us are beyond. If we kept doing everything the same as we're doing just now, the spend would outstrip the resource we get in. That's around achievement of targets, some of the pressures you've heard already today. Prescribing, which we haven't really touched on today, but prescribing new drugs, changing use of drugs. You've seen quite a lot of media coverage around that, so that brings a pressure. The majority of our costs are actually staffing, and there's a modest pay award, usually planned for each year, but there are also changes around pensions, national insurance, etc., which, because it's our largest spend, will bring with it additional costs. There's a building there, but what I really mean is there's building costs. We also have new technology, I think that's been referred to already, whether that be new medical equipment, whether it be new IT that will actually help us do things better, but that brings costs. And last but not least, the change in population, the change in demographics. No different in this area than we've got elsewhere. And I think for us, looking forward, to make sure that we don't get into the financial position. If you get into financial difficulty, it means the organisational effort goes towards that and not actually the things that are important around treating patients. So it's really important that we do keep ourselves in financial balance. And just to tie it into, that's the importance of the clinical services review. To make sure we keep in balance, we need to change what we do and how we do it to make sure we can keep meeting all the demands that come forward.
Thank you, Fiona. Any points on our financial position?
Just well done, Fiona.
I agree with that. Okay, so. Okay, so that brings us to the end of our formal presentations to you, but I recognise that while we've tried to cover most of the board's activities, then there might be issues that don't naturally fall within some of those headings. So this is the opportunity, just if there's anything still that we haven't covered that you wanted to raise with the senior team, then this is your opportunity to do that. So is there anything that you still have a burning question that you want to ask of someone? Okay. Yes, could you? Yeah.
It's the housing, social housing link, and I think this is an important one for the board to look at. Medical housing needs assessment seems to be long delays in when applications from local councils come in, and there's a delay before that comes back. And I just wondered if it's as basic as, is there insufficient staff to meet that?
Okay, I'm not familiar with that, so I don't know if there's any person who makes that, who can take that, or we need to take that away and have a look at that.
I think we're not aware of that,
Yeah,
Teresa,
so-
but I think we would.
Okay, that would be good.
It was something which used to vest in public health, but it's actually delivered by the local councils by a private contract now, so it's not actually something which we, the NHS, are doing, but we can certainly
Rather
help
than guess, we'll
direct the
look at it.
question.
Maybe GPs that do it.
Partnership working now.
Yeah.
Okay, no, we'll make sure that's.